Good morning, distinguished academics from KDU and other universities, invited guests, students, and ladies and gentlemen. We welcome you all to the medical technical sessions of the 8th International Research Conference at KDU. Our first technical session today will be on community medicine. I cordially invite our chairperson of the session, Professor Rohini Dissanayake, to take her seat at the head table. Professor Rohini Dissanayake is a senior professor of community medicine at the Faculty of Medicine at KDU. She is the emeritus professor of community medicine from the University of Colombo. She played an integral role in bringing about medical curriculum change at the University of Colombo. She is also the chairperson of the National Health Research Council of the Ministry of Health, Sri Lanka. Over to you, madam.
Good morning, everyone. It gives me great pleasure to welcome all of you to the technical session on community medicine and epidemiology. A word of welcome to the Dean of the Faculty of Medicine, Professor Ariratna, all distinguished invitees and academics, as well as the researchers who are here to present the papers. I also would like to welcome the students of the Kottalavada Defence University to this session. To start with, we have 5 papers for presentation. It's best that I indicate to you some of the ground rules so that we actually keep to time. It's very important that we finish on time because the next one will start also so that we could get on with the other one as well at the correct time. Now, each paper is allowed 15 minutes. You will be allowed 10 minutes to present the paper, and at 7 minutes there will be a red light coming on. So it's at 7 minutes, but you could go on for another 3 minutes, and at 10 minutes our rapporteur will ring the bell, and if you still need some more time and go on, she will ring the bell twice at 12 minutes, and that means we have to curtail the questioning time. So let me now start with the first paper. The first paper is titled Awareness, Attitude, Preventive Measures Practiced Towards Dengue Fever by the Teachers of Colombo District. It's presented by M. Pavithra, V.S. Opatha, R.C. Palliyaguruge, and WDN Dissanayake. The paper is presented by Dr. M. Pavithra, and they are of the Faculty of Medicine, University of Colombo, Sri Lanka. Over to you, please.
It is my great pleasure to start this session with our research which we have carried out among school teachers to describe the awareness, attitudes and preventive measures practiced towards dengue fever. Basically, these are the topics I would be covering in this next 10 minutes. Dengue fever is endemic in Sri Lanka. There has been more cases reported from Western Province. In Colombo district, 34% of cases were from school-going children. Most adult deaths were reported by the epidemiology unit from 15 to 30 age group, where the A-level school children also come under. Dengue fever is a viral infection. It is spread by Aedes species mosquitoes, which bite human beings in mornings and in late afternoons, during which time period the school children stay at school. School is a place where people from different societies, such as urban, suburban, and rural, gather. Teachers can provide the information regarding dengue fever to the students, and they can provide the leadership to implement the preventive practices at schools, and also they can motivate the children to do so at their houses as well. The school is becoming a major target for the prevention of communicable as well as non-communicable diseases. Kamis and others have carried out a study in 2009 regarding knowledge attitude prevention of dengue fever among teachers, students and supervisors in Saudi Arabia, and they have found out the knowledge has been insufficient among all three groups. There has been no other similar studies reported in South Asian region. So our objective was to describe the awareness attitude and preventive measures taken against dengue fever among school teachers and their sources of information in selected 3 schools in Colombo district. This was a cross-sectional study. We selected 3 schools in Colombo district. We recruited 120 teachers from a systematic sampling system where we got 40 teachers per school by getting every 3rd teacher from the register. We excluded the teachers in the administration. We provided a self-administered questionnaire consisting of awareness, attitudes and prevention sections. We had a cumulative scoring system for the awareness and prevention sections where the maximum possible scores were 22 and 17 respectively. The attitudes was not scored because there were only 3 questions and they had no definite right or wrong answers. After that, referring to Kamis and others, we grouped the scores that the teachers have obtained based on mean and SD. Good score group if they have obtained more than mean plus 1 SD. Fair score group if they have obtained in between mean plus 1 SD and mean minus 1 SD. And poor score group if they have obtained less than mean minus 1 SD. The response rate was 87.5%, giving a total of 105 teachers. 64.8% were degree holders. A quarter of them were having science as their subject of interest. Half of them were teaching to grade 12 and 13. According to the grouping system I mentioned above, only 20% obtained good score in the awareness section. Fair score was obtained by 68% and 12% obtained poor score. The breeding sites were correctly mentioned by most of the teachers, but they also mentioned the other breeding sites which were wrong. 20% of the teachers didn't know the primary management of dengue fever, and a small percent still believe that giving aspirin is one of the options. In the attitude section, we asked who is most responsible for the prevention of dengue fever. There, we got a more positive answer where 65% of the teachers believed that they themselves were responsible for the prevention. This is a good finding because if they have felt that they are responsible, then we can motivate them to practice the preventive methods. When we asked about the satisfaction with the government regarding prevention of dengue fever, 50% of them were not satisfied. According to the scoring group I mentioned above, in the prevention section, only 15% obtained good score. As same as for awareness, more people scored fair score, and 20% obtained poor score. Most of them were destroying the possible mosquito breeding sites, but they were not practicing other mosquito controlling methods. Interestingly, 81% of the teachers were teaching regarding dengue fever to the students. But I have mentioned above, only a small amount of percent were having a good awareness score, but they were teaching the students, which means we have to provide an adequate and correct information regarding dengue fever to the teachers so that they can teach it to the students. The providing knowledge is also very important because in our study, 80% of the teachers believe that the knowledge they are having regarding the dengue fever is the motive for their practices. So we went on and assessed whether there is any association between awareness and preventive measures. There we found out the group with a good awareness score was having a higher mean of prevention score of 10.81. When we had the plotted graph in between the row scores of awareness and prevention, the people who were having good awareness were having good prevention score. There was a significant association. Then we went on and assessed by doing analysis of variance table to assess the prevention score mean difference in between the awareness score groups. We found out that the group with a good awareness score was having a statistically significant higher preventive score compared with other two groups. There was no statistically significant difference in between fair and poor awareness score groups. As I have mentioned before, only a small amount of percentage of teachers, as I have mentioned before, a higher amount of teachers were having fair awareness score. But they all had to be moved from fair awareness score group to good awareness score group so that they can have a good preventive practices. So this also implies that the teachers should be provided with more knowledge. So the results that I have described above all points toward that the teachers should be provided with adequate, sufficient, correct information regarding dengue fever. How are we going to give the information? So we asked from the teachers. They mentioned the preferred source of information was the television, followed by other sources. So the future health promotion programs to deliver the knowledge regarding dengue fever to the teachers should focus more on media to provide the information. As summary, I would like to conclude by saying the awareness of dengue fever among teachers remain unsatisfactory. Good awareness has led to good practices. Teachers could be used as an important tool to provide the knowledge regarding dengue fever, thereby to reduce the burden of dengue. These are the references, and I would like to acknowledge the Community Stream Student Research Program, Faculty of Medicine, Colombo, to provide us an opportunity to carry out this research. And I would also like to thank the principals of the 3 schools and the participants. Thank you very much for listening.
Thank you, Dr. Pavithra.
Thank you.
You have kept to time, so we have a time for discussion. The paper is open for any questions, clarifications. May I ask you a question from the chair?
Yes, madam.
Did you ask the teachers whether they actually discuss with students prevention of dengue?
We didn't specifically ask about that, madam. We just asked whether they are teaching the students regarding dengue fever. That's all. We didn't specifically mention about the prevention.
Okay. What were the schools you studied? Were they rural, urban, or?
No, Devi Balika Vidyala, Ashoka Vidyala and Ananda College. This was selected mainly because of convenience. There were no specific sampling methods.
So we would agree that it's actually from Colombo Municipal Council area.
Yes.
Because Colombo district is so huge.
Yes.
So it's eminently urban areas where there is transmission. And just a clarification, the current pattern of transmission has shown that the classical biting in the morning and in the evening does not prevail anymore. That they have changed their biting habits, and biting can go on at any time of the day or evening or night, because we imagine that it's only in the morning or evening, because that was what was there classically, but it has changed. Any further questions, please? In the absence of any more questions, thank you very much, Dr. Pavithra. We thank you and your co-researchers for presenting this paper. No doubt an important paper. May I now